So, a 64-year-old female hailing from Dadbalapur, she is a homemaker. She belongs to lower middle class according to modified Kupaswamy classification. She presented with the chief complaints of a lump in her right breast since 1 month. History of presenting illness. She was apparently normal 1 month back when she incidentally noticed a lump in the outer aspect of her right breast, which was initially of a size of a marble, later progressed to the size of a lemon. Which is not associated with pain. There were no skin changes over the lump. There was no history of discharge or pain over the nipple. There was no history of nipple changes or retraction of the nipple. There was no history of swelling elsewhere in the body. There was no history of trauma to the breast. There was no history of any bony pain or cough. There was no history of weight loss. Coming to past history, she is a known case of hypertension and diabetes since 10 years. She is on medication for that, for tablet Telma and tablet Glycomet. She's not a known case of she's not a known case of tuberculosis or asthma. Coming to surgical history, she is tuberctomized. There are no other history of surgeries, no history of prior hospitalizations. Coming to personal history, her diet is mixed, appetite is normal, sleep is adequate, and bowel and bladder habits are regular. There are no addictive habits. There is no malignancy in her family. Coming to menstrual and obstetric history, she attained her menarche at the age of 15. She is postmenopausal. Her last menstrual period was 15 years ago. Her previous menstrual cycles were regular and uneventful. Coming to obstetric history, she is para 3, living 3, with no abortion or stillbirth. All the children were through normal vaginal delivery, and she had breastfed all the children until 1 year of age. Her age at the first childbirth was 17 years. There was no history of oral contraceptive pill usage. Coming to general physical examination, patient is moderately built, well nourished, conscious, cooperative, and oriented to time, place, and person. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. She was afebrile, pulse rate being 84 beats per minute, BP being 130/90 mmHg, BMI 23.8, BSA 1.73. There was no spinal tenderness. Coming to local examination, with a verbal informed consent, patient was examined in a well lit room. She was examined in sitting, semi recumbent, and recumbent position. Inspection was done with the hands on the side, hands above the head, hands over the waist, and bending forward, and hands against the wall positions. Both the breasts appear similar in size, shape, and symmetry was maintained. There was no swelling seen over the four quadrants of the breasts. Skin over the breasts appeared normal, no redness, eczema, or engorged veins, no dimpling, puckering, retraction, or purely orange appearances. There was no nodule or ulceration seen. Nipple on the both sides appear symmetrical at the same level. There was no discharge from the nipple. Palpation, there was coming to palpation, there was no rise in temperature. There was mild tenderness present on examination in the right breast. 4 into 5 centimeter single palpable mass lump was present in the upper outer quadrant in the right breast. It was firm in consistency, well defined margin. It was mobile along the direction of the muscles, and but it was adhered to the skin. Skin was not pinchable over the mass. The mass appeared tethered to the skin. There was no nipple retraction or discharge from the nipple on pressing. On the opposite left breast was normal. Right axilla and left axilla examinations were normal. Supraclavicular fossa on the both sides were also normal. Coming to systemic examination, cardiovascular system, both the heart sounds were heard, no murmurs were heard. Respiratory system examination, both the air entry was equal on the both the sides, normal vesicular breath sounds were heard. Coming to per abdomen examination, it was soft, no organomegaly. CNS examination, there were no focal neurological deficits. PS, PV, PR gynecological examination was not performed as the patient was not comfortable for that examination. Coming to summary, 64-year-old lady, postmenopausal, hypertensive, and diabetic. Presented with the complaints of lump in her right breast since 1 month. 4 into 5 centimeter mass was palpable without lymphadenopathy. My provisional diagnosis at this point would be carcinoma right breast, CT4B and 0M0 stage 3B, as I suspect that there was a skin tethering. I would like to investigate this patient with blood investigations like complete blood count, liver function test, renal function test, coagulation profile, serum electrolytes, and serology. Imaging with bilateral mammogram and then core needle biopsy. IHC markers for ER, PR, HER2, and Ki67. Metastatic workup with chest X-ray and USG abdomen and pelvis. Since she is locally advanced, I would like to also consider HRCT thorax and bone scan. My management will be IHC based neoadjuvant chemotherapy followed by assessment for surgery. I would like to subject the patient for modified radical mastectomy followed by adjuvant radiation. Um, Adjuvant radiation, I would like to start off with planning for it. I would like to immobilize the patient in the supine position with arms above the head, and then thermoplastic cast over the thorax. And I would like to take the patient for the CT simulation scan with markings over the chest wall. Over the chest wall, superior border being the clavicular head, inferior border being the 2 centimeters below the inframammary fold, medial border being the midline, lateral border being the mid axillary line. I would mark these borders, and I would also like to mark the scar with a lead or a copper wire, and then take a CT simulation scan of 5 mm cuts from mandible to the lower border of liver. And then I would like to contour the CTV for CTV, that is the left chest wall, the right chest wall, according to RTOG or Estro guidelines, and give a margin of 1 centimeter all around the CTV, 1 centimeters all around the CTV, and 5 mm towards the lung, and mark this target volume for 40 gray in 15 fraction. If there is indication for SCF, I would like to contour the SCF as well. And followed by, I would evaluate the plan, and then during the treatment, during the course of the treatment, if there is any acute toxicities like dermatitis or dysphagia, I would like to address those and manage those. And followed by, I would like to advise the patient based on the IHCs. I would like to advise the patient on targeted or hormonal therapy, and then follow up.